Okay, thank you very much, Dr. Irenga. Next, I think you invite them next time. Good morning, everybody. Today I'm going to present on the epidemiological profile of obstetric ultrasound attendees, our experience from the time that we started screening, from the time that we started offering obstetric ultrasound, that was late 2019. Right. Okay, as a background, we are aware that most antenatal care is the most utilized maternity care in Zimbabwe. From previous researches, it has been estimated that our ANC coverage is above 80%. It is against this background that ANC then becomes a platform to promote health and ensure safe delivery. And ultrasound services play a critical role in this regard. How does it play a critical role? By identifying at-risk pregnancies and directing those at-risk pregnancies, at-risk pregnancies to deliver in a hospital setting. Ultrasound also has a role in managing obstetric complications. So it is against this background that City of Harare started offering obstetric ultrasound services late 2019, and after a Ministry of Health rollout of ultrasound services nationwide. So this is just a conceptual framework trying to explain what I was highlighting. We are in a setting with a poor socioeconomic status. And it is against this background, because of poor socioeconomics, that we have not been having ultrasound services in our units, and also lack of skilled service providers in obstetric ultrasound services. Because of these factors, you end up having undiagnosed multiple pregnancies. The midwife at a clinic in Heathcliff, at a clinic in Mavuku, just to find twins in labor ward. You end up having also undiagnosed placental abnormalities, things like morbidly adherent placentas, things like placenta previa. And these things, because we get them by accident, we end up having complications like postpartum hemorrhage. Also, because of lack of ultrasound services, skilled providers, we ended up having ruptured ectopic pregnancies, antenatal bleeding, and the overall outcome is we end up having poor pregnancy outcomes. So this is the conceptual framework that we've been working. So from the time that we started offering obstetric ultrasound services, what we've been doing, I think we borrowed this from Dr. Irenga. Dr. Irenga always say, we don't want to do zero tillage. Zero tillage is a concept where people just go to work, come back, go home, go to work, come back, go home, go to work, come back, go home. So what we have done is we don't want to work like that. We have designed a data collection tool, an electronic data collection tool. I will show you a sample of the electronic data collection tool. So we do real-time data capturing as health service providers are scanning patients. So this kind of study that we have done is kind of a prospective cross-sectional study, because we are scanning, as we are scanning patients, data is collected exactly like what is happening at the central hospitals, and we document, or we keep our images, both sine loop and static images for standard planes. We are using, for the benefit of everybody, a simple machine, a low level basic 2D, which offers 2D basic mode gray imaging with sine loop M mode and power Doppler capabilities. And it is a trans-abdominal convex linear probe operating at frequencies 5 to 5.4 and a transvaginal probe operating frequency 9 to 9.4. It does not have power color Doppler abilities. So this is an image of the simple machines that we are using. We have two, one at Edith Opperman and another at Warren Park Clinic. So from November 2019 to date, we have scanned more than 417. But from the time that we designed the data collection tool, we have 417 patients that are in our records. That is from November 2019 up to May 2021. So what we did in our methodology of the study was to clean the data for deleting multiple entries and also entries with missing information. So we were left with the 417 entries for data analysis. And we analyze our data using EpiInfo, Epi7, that is the Epi7 version of EpiInfo. We mainly did univariate data analysis, but we intend to do also even bivariate data analysis as more. So this is a sample of our data collection tool. As we are scanning patient, we get the date, the month, the year, the name of the patient, the age, parity, gravidarum. We ask are we checking the book also gestational age at booking, gestational age at first, at the trimester at first scanning. So basically this is more of demographics. Then we also do ask on the indications for scanning, why the patient wants to be scanned. We tick what is appropriate. We also do a form of risk assessment by asking past medical surgical history and obstetric history, like diabetes, gestational diabetes, chronic hypertension, PIH, and also these are the obstetric, relevant obstetric history, like miscarriages, preterm labor, stillbirths, early neonatal deaths. We have also added recently this other section on previous C-section and uterine surgery, social history and the technical. So this is the data collection tool that we use. Then when we start to scan the patient, then we collect information on number of fetuses, presentation, like what we also added this issue of placental findings. Right. So these are our findings from the 417 patients that we have scanned so far. So in terms of demographics, the median age of the patients, you can see here the number of the patients that we have scanned is 470. That we have scanned and recorded. Like what I said, we have scanned more than this, but there's ones we captured in our system are 470. So median age is 26, median parity, so 26 with the lower quartile of 22, upper quartile of 31, median parity 1, median gravidarum 2. Most of the women that we have scanned have achieved at least secondary education up to Form 4. You can see here 81.3%, followed by tertiary education, then primary. So these are our milestones. At the two facility, the blue here is Edith Opperman, which is EO, and the yellow is Warren Park. So from November 2019, these are the patients that we have been scanning per month. So you can see this is more of a trend analysis. We have scanned more patients at Edith Opperman compared to Warren Park. Basically, this is explained by staff challenges, especially 2019, and here in June, July, if you remember, that was the time that we were doing a national training, so we were not capturing the statistics, but we scanned more than 300 patients during that time when we trained people from the provinces. We have scanned about 72% of 72% of the patients we have scanned are from Edith Opperman, and 28% have been scanned at Warren Park. And in terms of indications for scanning, fetal well-being is the commonest indication with 65%, followed by pregnancy dating. Then presentation, where health workers wanted to know the presentation of the fetus, probably near term, big, small for deaths, and the rest goes like that. And in terms of gestational age at booking, you find that majority of our women are booking around 25 weeks gestation, with a lower quartile of 21, upper quartile of 30. So, and it is against this background. I remember, I think a week or two ago, Dr. Wenge was asking a person, it's important for us probably to work on, as the trend we are moving towards is about inverting the pyramid of care. We want more women coming to book earlier than 25 weeks gestation, is that will give us a window of opportunity to detect a lot of other things. And in terms of trimester at first scanning, majority of our women have been scanned in the second trimester, which is 45.8%, and third trimester, 44.3%, and only 9.5% have been have been scanned in the first trimester. From the two, I'm sure you saw that there is a question where we do ask a risk assessment. So majority of the women that we have scanned don't have any risk factors, or don't have any risks in terms of previous history, but 15 had history of miscarriages, 13 PIH, and the others with smaller numbers. HIV status, 82, majority of our women, that is 82, were HIV negative. And of the HIV positive, 72% were on ART and 28% were not yet on ART. The reason why these ones were not yet on ART, they were newly diagnosed at booking, so they had not yet been initiated on ART. Then also in terms of family history, majority of the women that we scanned responded no family history of any of these risk diseases. And chronic hypertension was in 7%, diabetes 2.5%, and PIH in 1.4%. Like what I said, we added also this question on previous cesarean section. Basically, we added this question because we also want, with time, we want to assess that those women with previous cesarean section and uterine surgery risk vis-a-vis morbidly adherent placentas. So far we have, from the time we added this question, we have scanned about 150 patients, and of them, 14 had previous cesarean sections, and 9 had previous uterine surgeries. So here are our scanning outcomes. So like what I said, we have scanned 417 women with the documented records, and 96% of them were singleton, and 4% were twins. And in terms of fetal presentation, in almost 82%, they were cephalic presentation, 16, about 17% breech, and transverse and oblique in the other smaller percentages. The scanning conditions were regarded as good in about 85% of the women that we scanned. We were limited by maternal habitus in about 6%, and limited by previous scar in about 0.7%. And one of the questions on our questionnaire is, what is the basis of pregnancy dating that we finally use? So in 47%, we used the last normal period to date our pregnancy, and in about 27%, we used a T3 scan. I know Dr. Verenga says we don't use the T3 scan for dating, but for EDD. Anyway, so, and in 21%, T2 scan was used for dating the pregnancy, and in about 5%, T1 scan was used for dating the pregnancy. Placenta position, in 44.3%, the placenta was located upper anterior, and in 45% upper posterior, and the smaller percentage fundal in about 4%, right lateral in 3.3%, low anterior in 2.5%, and low posterior in 1.3%. We have not analyzed this one yet. Like what I said, it's a variable. I mean, we have not analyzed this one yet because we added this question a few months ago, so we still have few small numbers. But we feel that, yes, there are some things that we will not be able to see because our machine does not have color Doppler capabilities. But I'm sure things like placenta lacunae, placenta leaks, placenta bulging, diminishing of the clear zone, myometrial thinning, we should be able to see that with our basic 2D imaging. So we are specifically targeting women who have previous cesarean sections, previous uterine surgery, to see if we will be able. But I'm sure with time, probably when we get also machines with color Doppler capabilities, we'll be able to also even to look at these other signs of abnormal placental findings, suggestive of morbidly adherent placentas. And we also intend to analyze, to do some risk assessment to see that in women with sonographic features of morbidly adherent placenta, is there a relationship between previous C-section and that, and also is there a statistically significant relationship in women with previous uterine surgery with the sonographic features of morbidly adherent placentas? Of the women that we have scanned, majority, almost 97%, had normal amniotic fluid findings. Polyhydramnios was in 2.3%, and oligohydramnios, polyhydramnios in 0.8%, and oligohydramnios in 2.3%. Then this one is also an incomplete, but we were just wanting to compare. We stratified the estimated fetal weight that we got with the gestational age, and we want to compare our finding. HCC here is Harare City, then standard. We want to compare this with weights based on other standard charts. I'm sure there's been a lot of talk of which charts do we use. So we wanted to compare the weights of our findings compared to those of other standard charts like the WHO charts or other standards charts. The final diagnosis was normal growth in majority. Then we had some SGAs, multiple pregnancy, and oligohydramnios and polyhydramnios in a few. So, ladies and gentlemen, I think this is most of my presentation. I'm now just going to be showing you some pictures of images that we've been taking with our simple machine. You can still get good and beautiful images. This is an AC plane, abdominal plane, with our simple Eden machine. head circumference plane with our simple machines. This was a case with severe bilateral ventriculomegaly that we detected at Warren Park sometime in 2019, December of 2019. We referred this woman to perinatal fetal medicine unit. Femur length. With our simple machine, as you start to explore using the machine, we can also do umbilical artery Dopplers, so and get the relevant pulsatility index values and refer where need be. We can also do even MCA. It has that capacity that you can do the mid-cerebral artery Dopplers. Even the ductus venosus, the machine can also do, as long as one assembles the relevant vessel. A little bit of some anatomy. You can see here some orbits. These are two different patients, although the images look similar. Heart, situs, apex position. These were two images that we superimposed here. We can see the stomach and the heart was pointing also on the left side. The four-chamber view, well seen here. A left ventricular outflow tract, I'm sure you can see the boot here. Right ventricular outflow tract with our main pulmonary artery bifurcation. And the three vessel tracheal view in some of the patients that we have been scanning. We have also, before we refer the patients to perinatal fetal medicine units, we have also, those that are my first trimesters, we have also been doing some first trimester scanning. You can see here a crown ramp measurement, which was 77.2, corresponding to 13 weeks, 5 days. First trimester head, you can see the brain there. Twin pregnancies, you can see the placenta lambda sign here, and twin pregnancies again here. You can see the membrane separating the two twins, and even in the same. So ladies and gentlemen, in conclusion, we have learned that is from the time that we've been doing this obstetric ultrasound in our units, it has allowed us timely referral of some women, like those with multiple pregnancies, those we suspect things like morbidly adherent placentas, placenta previa, abnormal lie at term, congenital anomalies like the case I showed you with bilateral, severe bilateral ventriculomegaly, or macrosomic babies where we feel that it's not proper, it's not safe to deliver them at a local clinic. We have also, for the few months that we have been scanning, it has been an opportunity for us also to create demand even for early prediction or early screening for leading causes of maternal perinatal mortality morbidity, like preterm labor, eclampsia, and FGR, and aneuploidy. And it has also been an opportunity also for early pregnancy setting, like the case I showed you, where we could do crown ramp length in those who come in the first trimester, and then we follow them. If they wish, we refer them for surveillance at the central hospitals should there be a need. Then viability assessments, and also those with post-dates, and like the images that I showed you, we can also do Doppler velocimetry with even this simple machine. You can do umbilical artery Doppler, MCA, and ductus venosus, as long as you assemble the relevant vessels. Of late, we have received some printers, so no job is finished until the paperwork is done. So now we are no longer doing manual writing, but we are just typing our reports and also giving to clients a service that they also like. Otherwise, thank you very much. I think that's the end of my presentation. Thank you. Over to you, Chair. Yeah, back to you, Chair.
Thank you so much, Dr. Madembo. This is a wonderful presentation. I'm lost for words, to be honest. So let me leave the room to my colleagues in the meeting to pass comment. But you are doing a great job. I'll open the floor to all of us.
Morning, Dr. Verenga.
Morning, Dr.
Yeah, mine is just a comment. I just wanted to say that the team is doing very well, and I think the services are making a difference at the local clinics, and we are also seeing lots of patients that they are sending, which means that a lot of screening is being done at primary care level. So thank you very much, Dr. Madembo, for that effort.
Okay, thank you.
Thank you, Dr. Madembo, for that wonderful presentation. I was also pleasantly surprised by the amount of work that you're doing. It's quite refreshing. I'm also aware of the many referrals that you've been sending. I wanted to ask, though, a question. On the patients that you dated using the LMP, what was the reason that you ended up using the LMP?
Okay, basically, the issue is that there was no discrepancy between the LMP given dates and the scan findings. So the final pregnancy dating would be based on the LMP. I stand to be guided. So that was the rationale, basically. The rationale was that there was no discrepancy between LMP and scanning findings. So the final dating, we would consider it as based on LMP.
Okay, I assume by that you mean that you had done, if it's a second trimester or third trimester, you had circumference, and that's the one which was coinciding with the LMP.
Sure.
Is that mine? Oh, okay, yes. No, that's fine then.
Okay.
My question, Dr. Madembo, is to do with your team. How many of your team are also doing this work?
Yeah, so on that one, we have quite a challenge. Originally, we trained people at Heathcliff because of some challenges. Our desire was to train people at Edith Opperman, but we got staff from Heathcliff. So unfortunately, the Heathcliff team has not been active because we ended up having to move the machine to Edith Opperman because Heathcliff was a bit far, and even in terms of volume and demand for the service, we thought Edith Opperman is strategically positioned. It's not far. It's probably the busiest polyclinic, and we felt that the service is better. We would get better return on investment if we offer the service at Edith Opperman. So unfortunately, we don't have anyone trained at Edith Opperman. So that's one challenge. But at Warren Park, yeah, we trained 3 people, 1 has left, so we are left with 2. Those ones, they scan here and then. Yeah, the Warren Park team is scanning here and there, but staffing challenges remain. Just last year, City of Harare is a complement of about 300 midwives. Last year only, we lost almost 100. So a very high staff attrition, which now leaves a kind of skeletal staff. So you find that the same person who was trained then has competing demands at the clinic. So we desire to train more, to have more people trained, but it's that aspect here, staffing challenges. If our staffing challenges improve, definitely we would probably get in touch with you and ask some of our staff to come for training.
Yeah, especially in Operman, do you think, is there any chance that you could release one person from Edith Operman to come for training so that they can help you carry the burden? They can come for maybe 2 weeks. They can come to Sally for 2 weeks.
It's okay. I will present that request to the relevant stakeholders.
Okay. Then, do you think there's any chance to increase the number of clinics? Which other clinic do you think is busy? And another scan can be put at that clinic. That scans can be done.
Yeah, the possibilities there. City of Harare has 12 polyclinics. Polyclinics are those that do deliveries, but we have about 34 clinics that do ANC. Some of them, they don't do clinics. I mean, they don't do deliveries. So yes, there is room for another machine. We can put even at Highfield, and it can cater for the southern suburbs. That is Highfield, Glenview, Glenora, Budiriro. So people from all those can be referred to Highfield. It's also a polyclinic.
Great.
Ideally, if resources would permit, people would desire that each polyclinic have a machine.
Yeah. Yeah. Do you have any other questions for Dr. Madembo? So thank you so much, Dr. Madembo, for that wonderful presentation. I think we will ask you to present this at another bigger forum at some point, because I think it will be eye-opening to a number of people. I think we'll also invite guys from the ministry into that meeting. As well, the family development. Maybe I will talk to Dr. Gondongwe, who is now I think she's the deputy director now, to see what opportunities we can avail so that maybe you can present to the ministry, because I think they need to know what is happening. That this great program is really making a lot of impact. I think we are also trying to gather this data from the district, so that maybe we can have this presentation that looks at the whole program and whole national prenatal screening program using ultrasound. So yeah, thank you so much for doing this, and keep on doing the great work. And I hope the leaders at the council, they will release a nurse for Edith Operman so that they can help you to carry the burden. I think if we do that, you guys may scan even more patients than what you are doing, which will be great. And this kind of data excites us. Yeah, I think we will discuss the data issues probably at another time, but this is very exciting what you have done, Dr. Madembo. Thank you so much.